Good afternoon, students. I'm Dr. Orgu. This is the pharmacotherapy of ischemic heart disease, which is also called coronary arterial disease. So under these topics, we will try to discuss some of the components of coronary arterial disease or spectrums of ischemic heart disease, and we'll see their pharmacotherapeutic management. Okay. Ischemic heart disease or coronary heart disease is defined as just inadequate supply of blood and oxygen to the portion of myocardium, which typically occurs when there is an imbalance between myocardial oxygen supply and the demand. The most common cause of myocardial ischemia is the atherosclerotic disease of coronary artery. So in general, ischemic heart disease is an imbalance between myocardial oxygen and blood demand and supply. There is imbalance. The clinical presentations of ischemic heart disease. For ischemic heart disease is not a single disease. It is an ischemic spectrum of disease that starts with silent ischemia, the mild one, stable angina pectoris, unstable angina, myocardial infarction, and cardiomegaly and heart failure, particularly ischemic cardiomyopathy, and which will result in sudden cardiac death. Of these, there is what you call acute coronary syndrome, which is which includes unstable angina, non-ST elevated myocardial infarction, and ST elevated myocardial infarction. So, three of the spectrum of ischemic heart disease, that is unstable angina, non-ST elevated myocardial infarction, and ST elevated myocardial infarction, are grouped under ACS, acute coronary syndrome. We'll see what's acute coronary syndrome later on. So acute coronary syndrome is the spectrum of disease. Actually, presentation usually ischemic discomfort, which is explained by the patient. After the discomfort, if you work or investigate with ECG, there will be ST elevated myocardial infarction or non-ST elevated myocardial infarction. Non-ST elevated myocardial infarction can be unstable angina or non-ST elevated myocardial infarction, which can be differentiated based on the cardiac biomarkers. And this ST elevated myocardial infarction can be concluded from the ECG finding, and the final diagnosis of this acute coronary syndrome can be three of the spectrum: either unstable angina or non-ST elevated myocardial infarction and ST elevated myocardial infarction. To begin with, unstable angina is defined as angina pectoris or equivalent ischemic discomfort with at least one of the following three features. The first one, it occurs at rest or with minimal exertion, usually lasting greater than 10 minutes. It's severe and of new onset, that is within the period 4 to 6 weeks. It's crescendo pattern. Crescendo means it's increasing in terms of severity, timing, prolonged period of time, and frequent than the prior occurrence. There is no elevation in cardiac biomarkers like troponin or CKMP with or without electrocardiogram changes in indicators of ischemia. If these three of the above is at least one of the three above is occurred together with the raise in cardiac troponin or CKMP, it is non-ST elevated myocardial infarction. But if there is no rise in the cardiac biomarkers, it is called unstable angina. So non-ST elevated myocardial infarction generally presents as prolonged, more intense rest angina or angina equivalent, and the same manifestation as those in unstable angina, but in whom an elevation in troponin or CKMP is present. So the main difference between unstable angina and a non-ST elevated myocardial infarction is whether there is elevated cardiac biomarkers or not. However, we usually treat non-ST elevated myocardial infarction and unstable angina similarly. There is no such management difference because It takes time to rise for the cardiac biomarkers, even though there is no elevation in cardiac biomarkers. We can't say that, we can't rule out the non-ST elevated myocardial infarction. Since an elevation in troponins and or CKB may not be detectable for hours after presentation, unstable angina and a non-ST elevated myocardial infarction are frequently indistinguishable at initial evaluation. Hence, the management will be similar. What are the risk factors for coronary arterial disease or ischemic heart disease? The risk factors can be grouped as modifiable and non-modifiable risk factors. Non-modifiable means we can't change the risk. For example, age, usually with old age, being male, and a family history of premature coronary arterial disease. These are non-modifiable risk factors. Modifiable or independent risk factors, these are dyslipidemias or hyperlipidemia, raised blood pressure, diabetes mellitus, metabolic syndrome, cigar smoking, obesity, being sedentary lifestyle, heavy alcohol intake, markers like elevated lipoproteins, hyper homocystinemia, elevated high sensitivity C-reactive proteins, coronary arterial calcification, which is detected upon imaging, are modifiable risk factors. High level of cholesterol, HDL cholesterol, is a protective factor. So HDL cholesterol greater than 60 milligram per deciliter can be counted as a negative risk factor, which means its presence removes one risk factor from the total count. So having high level of HDL is a preventive factor for the development of ischemic heart disease. History and physical examination, usually they will have chest pain, ill-defined type of chest pain, usually substernal region, or sometimes in the epigastrium, which will radiate to the neck, left shoulder, and left arm. There is a Levin sign. Levin sign means the patient will fix their hand and put it on their sternum to show you that, or to explain it that the pain is substernal and excusing type. Anginal equivalent such as dyspnea and epigastric discomfort, especially in women, diabetes mellitus and CKD, elderly, can be present with angina equivalent, and they will lack typical manifestations. If large area of myocardial ischemia is involved, the patient will have excessive sweating or diaphoresis, pale cool skin, sinus tachycardia, and S3 or S4 on examination, basilar rates, and sometimes the patient will be hypotensive. So if this is occur or manifested in any patient, it tells you a bit severe form of ischemia. Cardiac biomarkers, like we have said, elevated CKMB and troponins to differentiate whether there is the ischemia is non-ST elevated or unstable angina. Elevated CKMB and troponin increase risk for days, or it will show you recurrent the chance of recurrent myocardial infarction. Minor troponin elevation can be caused by congestive heart failure, myocarditis, and pulmonary thromboembolism without acute coronary syndrome. But if the troponin is that of troponin T, it's almost specific to cardiac conditions. The timing of cardiac biomarker elevation matters. Here, for example, creatine kinase will have onset similarity with troponin, that is about 3 to 12 hours. The peak is for creatine kinase total maybe is about 1 day, but it's almost similar to with the troponins. The difference here is the creatine kinase will return to normal within 2 days, but troponins will stay for about 10 days, even up to 14 days. That's very important in following the patient. Myoglobin is the earliest to rise within 1 to 4 hours, and it will return to normal within 24 hours. And lactate dehydrogenase again will rise within 12 hours of onset, and the peaks within 2 days, and it will return to normal within 6 to 8 days. So you commonly use troponin, which is very cardiac specific, and the long duration of stay in the serum will help for following the patients. Here is the graphic illustration of the serum markers in acute myocardial infarction. So this cardiac troponin with perfusion or without perfusion. With perfusion, it will return to normal within short period of time. But if there is no perfusion or it will stay for long period of time. For example, here the dot 1 is for cardiac troponin with reperfusion, which will reach peaks within a short period of time, and it will return to normal within a short period of time. But if there is no perfusion, the solid line, it will stay for a long period of time. You need to know that these cardiac biomarkers are not usually being released by cardiac muscle. They are the indicators for cardiac injury. Mainstay of therapy in unstable angina and elevated myocardial infarction relief symptoms as chest pain, inhibition of coagulation cascade by using antiplatelet and antithrombin drugs, decreasing myocardial oxygen demand in the cardiovascular workload, coronary revascularization, which is the mainstay of management, risk factor modification. Elevated myocardial infarction. Its pathogenesis is the complete and the sudden occlusion of the blood supply to the myocardium, with resultant coagulation cascade and activation of platelet, coagulation factor, and the formation of thrombin and fibrin. Clinical features almost similar to the previous non-ST elevated myocardial infarction and unstable angina, but a bit severe form. The ECG finding of the ST elevated, as the name indicates, there is ST segment elevation. And the cardiac biomarkers will be raised. Even there will be leukocytosis in the absence of infection, and erythrocyte sedimentation rate will also be increased. Echocardiograph to look for any thrombi or wall motion abnormality, and Doppler detection to check for blood flow, and perfusion scanning can be indicated for ST elevated myocardial infarction. Initial management. The prognosis in ST elevated myocardial infarction is largely related to the occurrence of two of the general class of complications, that is arrhythmia and the pump failure, and the management designed on preventing the arrhythmia and the pump failure in patients with ST elevated segment myocardial infarction. The most common cause of death from ST elevated myocardial infarction is VF, which is ventricular fibrillation, and most of the patients will die within 24 hours of onset of symptoms. So it's emergency, yeah. ST elevated myocardial infarction or any acute coronary syndrome is an emergency condition. The goal of management is to control cardiac discomfort by giving nitroglycerin, preferably sublingual or IV nitroglycerin, which is vasodilator, morphine for pain relieving, beta blockers to decrease what? Demand, to decrease myocardial oxygen level demand, preferably by IV, then can be changed into PO. Rapid identification of patients who are candidates for urgent reperfusion therapy is very important, by the way. Not all patients will need reperfusion therapy, but we need to identify patients based upon this presentation, and that will not actually, that shouldn't take time for the isolation of patient or for characterization of patient or to which needs reperfusion or which do not need reperfusion therapy. It's better to over-treat the patient than under-treating in case of acute coronary syndrome. Triage of low-risk patient to the appropriate location in the hospital. If the patient will not need reperfusion therapy, we'll put them into the admission and no need of putting them in the emergency department. Avoidance of inappropriate discharge of patient with ST elevated myocardial infarction. Don't discharge patient with ST elevated myocardial infarction before stabilizing. So first of all, we need to put the patient on oxygen, bed rest, sedation, laxatives, and aspirin especially should be given just as the patient reaches to the emergency ward. And the diet rich in potassium and magnesium be given. Avoid any non-steroidal anti-inflammatory drugs except aspirin in patients with the acute coronary syndromes. These are the opioids that are indicated for management of pain in acute coronary syndrome. And the other part of management is to modify the risks. If the patient is a smoker, it's preferably counsel to stop smoking, to do physical activity. If there is the dyslipidemia or diabetes mellitus, to control the good glycemic control, and recommend a diet and weight reduction again. The home medication after stabilization, we will discharge the patient with antiplatelet, preferably clopidogrel for 9 to 12 months, preferably with addition to aspirin. Aspirin with clopidogrel. Clopidogrel has mortality benefits than clopidogrel or aspirin alone. We can again administer beta blockers, angiotensin converting enzyme inhibitors, or angiotensin receptor blockers. And statin is indicated in patients with acute coronary syndrome. You know statins, any drug, group under statins, like atorvastatin and lovastatin. They are HMG CoA reductase inhibitors, are very important in patients with dyslipidemia and acute coronary syndrome. Stable angina pectoris. This is episodic clinical syndromes due to transient myocardial ischemia. Usually males in about 70% of the case, and even greater portion of those less than 50 years of age. In less than 50 years of age, it can even contribute about 80% of the case, male. Women often have atypical presentation and history. A typical patient with angina pectoris is man greater than 50 years or woman greater than 60 years. Episodes of chest discomfort is almost similar to the previous one, but mild form. The patient will describe heaviness, pressure, squeezing, smothering, and choking, and only rarely as frank pain. It's not frank pain, but a bit heaviness around the sternum. And the patient localized over sternum with a clenched fist to indicate squeezing central and substernal discomfort, what we call it Levin sign. And it usually crescendo decrescendo in nature. It will start with severe form, but it will decrease in terms of severity, duration, and frequency. It typically lasts 2 to 5 minutes and can radiate to either shoulder or to both arms, to the back, interscapular region, or root of the neck and the jaw, teeth, and epigastrium. This is because of innervation, right? Because of innervation, it will radiate to this area. Episodes of angina typically are caused by exertion, like exercise, hurrying, even sexual activity can precipitate angina pectoris, or emotion, stress, anger, fright, frustration, and this all can be relieved by rest. If it's not relieved by rest, it's not stable angina pectoris. It is unstable angina pectoris. The main difference between unstable and stable is stable is relieved by rest. Unstable will not be relieved by rest, and it's a bit crescendo. There is what we call nocturnal angina, which is probably because of episodic tachycardia and diminished oxygenation as respiratory pattern changes during sleep, or expansions of intrathoracic blood volume that occurs with recumbence or in supine position that will diminish the oxygen supply and change in the respiratory pattern. So how do we manage the patient with stable angina pectoris? These are the components of management. Explanation, formulate the treatment plan, identify and treat patient with the aggravating conditions, adaptation of activity as needed. If there is any risk factors, especially modifiable one, treat them, like smoking. For dyslipidemia, statins, antiplatelets, aspirin, and clopidogrel should be indicated. And the drug therapy for angina, like that of other acute coronary syndromes, nitroglycerin, beta blockers, calcium channel blockers, whichever is available, we can administer. But beta blockers and nitrates are very important, especially during initial phase. And if there is massive ischemia, there is a place for revascularization. Do we need anticoagulation in patients with ischemic heart disease? Yes, if there are these indications, like anterior locations of the infarction, site of infarction matters, severe left ventricular dysfunction, heart failure, history of embolism, and echocardiographic evidence of mural thrombus, and if the patient's pulse rate is irregular, like atrial fibrillation, we need to put the patient on anticoagulation like warfarin and heparin. So, beta blockers are recommended as first-line therapy for controlling symptoms and improving exercise tolerance in patients with stable angina pectoris, whereas calcium channel blockers or long-acting nitrates are used if beta blockers are contraindicated poorly tolerated due to significant side effect, or in combination with beta blocker when initial therapy with beta blockers alone is not effective. So the first line of choice is beta blockers. If the beta blocker is not tolerated because of side effect or not effective, we can combine calcium channel blockers or long-acting nitrates like nitroglycerin. This is the management of unstable angina and non-steady elevated myocardial infarction. Nitrates, be cautious in patients at risk of hypotension like right ventricular infarction, because nitrates by itself will cause hypotension, and if the patient has underlying risk, it will further put the patient at risk of hypotension. Beta blockers like cardioselective, particularly metoprolol and atenolol, are preferable to non-cardioselective drugs like propranolol. So beta blockers, as you know, are contraindicated in patients with heart failure, bradycardia, and second and third degree arrhythmia. For the hypertensive patient, it's recommendable to give intravenous beta blockers. Antiplatelet therapy, aspirin, P2Y2 receptor blockers like clopidogrels are recommended. Even the combination is much better than either aspirin or clopidogrel alone. Anticoagulation, if the need arises, because if the patient has this risk, anterior location of the infarction, severe left ventricular dysfunction, heart failure, history of embolism, echocardiograph evidence of mural thrombus and atrial fibrillation, we need to put the patient on anticoagulation with either unfractionated heparin like large molecular heparin like heparin, and low molecular weight heparin like enoxaparin, rivaroxaban, or fondaparinux. These low molecular weights are preferable. Statin therapy with high intensity like atorvastatin and rosuvastatin are recommended. Coronary perfusion, percutaneous coronary intervention within 24 hours. Which one do you select? All are indicated for a single patient present with either unstable angina or non-steady elevated myocardial infarction. We need nitrates, we need beta blockers, we need antiplatelets, we need anticoagulation if the patient has risk, we need statin, and we need coronary reperfusion. But what's the difference if the patient is on ST elevated myocardial infarction? The difference is we need oxygen for arterial saturation less than 90%. We don't need oxygen here in patient with non-ST elevated and unstable angina. We don't need oxygen. But here for ST elevated myocardial infarction, because it's a bit severe form of the acute coronary syndrome, we need oxygen. Nitrates, as that of the previous one, we need antiplatelet therapy again, anticoagulation with low molecular weight heparin, preferably like enoxaparin, beta blockers, prompt reperfusion with percutaneous medication, and ideal first medical contact to PCI to within less than 90 minutes of occurrence of the ischemia, and statin therapy as soon as possible. So the difference between the previous and this one is almost they are similar, but we don't need the oxygen there. And again, we can add opioids or morphine, particularly for chest pain due to both non-ST elevated and ST elevated myocardial infarction. And in fact, in unstable angina also, we will need morphine. Here, medical therapy shown to improve morbidity and mortality in patients with non-coronary heart disease or ischemic heart disease includes: 1. Dual antiplatelet therapy or DAPT with aspirin and clopidogrel addition, beta blockers, or angiotensin converting enzyme inhibitors or angiotensin 2 receptor blockers. This will again help. HMG coreductase inhibitors or statins like atorvastatin, aldosterone antagonist like spironolactone or eplerenone in patients with left ventricular ejection fraction to less than 40% who have heart failure symptoms or diabetes mellitus. These are especially used when there is comorbid condition with ischemic heart disease or coronary arterial disease. The patients presenting emergency departments with chest pain and suspected acute coronary syndromes, meaning either unstable angina, non-ST elevated myocardial infarction, or ST elevated myocardial infarction, should be administered aspirin as soon as possible, together with oxygen, morphine, and nitroglycerin. Early anticoagulation therapy with aspirin reduces the rate of myocardial infarction and overall mortality in patients with acute coronary syndrome. And students, you have the case scenario or a quiz regarding this. It's presented in your slide or handouts. Please refer and do it. Thank you very much. I think I have 3 or 5 questions in the slides regarding the management of ischemic heart disease. Look at it, and if you have any question or suggestion or comments, you are welcome. Let's communicate through Telegram or email or any means possible. Thank you for your attention. Stay safe. Thank you very much.